Welcome to Module 5. In this module, we will talk about nutrition care process or NCP. So first, let's have an overview of the nutrition care process. You might learn this from your other classes, but here is an overview of the NCP, nutrition care process. So first of all, nutrition care process is a comprehensive model developed to standardize the process of nutrition care delivery. So it has four main components. First is nutrition assessment and reassessment. The second component or second step is nutrition diagnosis. The third one is nutrition intervention. And the last one is nutrition monitoring and evaluation. Remember, this is not a linear model. This is a circular model, which means we can go from nutrition monitoring and evaluation to nutrition assessment and reassessment. In some cases, we don't have to do that, but in some cases, we have to have nutrition assessment and reassessment after nutrition monitoring and evaluation. So if nutrition problem is resolved, then there is no need to have nutrition reassessment. But if the problem persists, then we have to have nutrition reassessment after having nutrition monitoring and evaluation. Nutrition assessment is the first step of nutrition care process, which is a comprehensive analysis of an individual's dietary evaluation, medication, psychosocial history, anthropometric data, biochemical data, and physical examination, as well as energy needs. So remember, nutrition care process and nutrition assessment, these are all kind of a comprehensive and standardized analysis of clients or individuals nutrition related problems. So nutrition care process first was developed in 2002 by the Academy, and it serves several objectives. So these are main objectives of nutrition care process. It reduces variation in documentation. It improves consistency and quality of individualized care. It provides a reliable and systematic process or workflow. It provides a consistent structure and framework. And it provides a common language for practice. It generates reliable outcomes and it focuses on evidence-based practice. So in clinical setting, we use nutrition care process terminology. So this terminology helps other healthcare providers and healthcare professionals to kind of understand the wordings and it kinds of helps communication between dietitians and other healthcare professionals. So before 2002, it was some kind of there were some kind of like difficulties when dietitians were trying to communicate with other healthcare professionals. But since then, since 2002, after developing of nutrition care process, dietitians and healthcare professionals in clinical setting can easily communicate with each other regarding nutrition related health problems of clients and patients. The NCP is not just for, in clinical setting. We can also practice nutrition care process in private setting. And as nutrition counselors, we can also use the nutrition care process. And these are the critical thinking skills required for the implementation of the NCP by nutrition counselors and by dietitians. So we have to determine the appropriate data to collect, determine the need for additional data, select assessment tools and procedures that match the situation. There are different assessment tools that we can utilize, but we have to kind of pick out the important and more relevant ones. And we have to apply the assessment tools in valid and reliable ways. We have to differentiate relevant from irrelevant data, distinguish important from unimportant data, and validate the data. So these are critical thinking we will need as nutrition counselors in order to carry out nutrition care process. So as I mentioned, nutrition care process consists of four interrelated steps. And remember, uh, nutrition care process is not a linear model, it's a circular model. So assessment and reassessment, diagnosis, intervention, monitoring, and evaluation. And we can use the acronym ADIME or ADIM or ADIME for NCP. And these four steps, we can also categorize them. Okay, we can categorize these four steps into two categories. Um, Problem identification and problem solving action. So for problem identification, we will use assessment and reassessment and diagnosis for problem identification. And for problem solving, we will have intervention, monitoring, and evaluation. So this is another kind of overview of nutrition um, care process. But remember, even though this looks like a linear model, but it is not. So we can go from nutrition monitoring and evaluation to nutrition reassessment. And each of these steps consist of different domains, and we will talk about that in later slides. So let's answer this question. What does the nutrition care process typically begin with? A detailed evaluation of the client's dietary habits, the direct initiation of nutrition therapy, referral and identification of a suspected problem, nutrition monitoring and evaluation. So nutrition care process begins with a referral and assumes that a problem has been previously suspected or identified. The option B is nutrition intervention. D is the last step of the nutrition care process. And option A is the nutrition assessment. So before getting into nutrition care process, we have to have kind of a suspicion or there should be some identified problems by other healthcare professionals, or We can get some referrals from other healthcare professionals in clinical setting in order to conduct nutrition care process. And this happens in clinical setting most of the time because like nurses and other healthcare professionals can conduct nutrition screening. And if they find a problem or if they suspect there is a problem, they can do referral to dietitians or nutrition counselors. And remember, this model does not contain nutrition screening. So screening is outside the circle. As I said, there is a terminology for nutrition care process, which kind of standardize the communication between dietitians and nutrition counselors uh, with between these professionals um, and other healthcare professionals. And as I said, each step, so we have 4 steps for nutrition care process, and each step provides a set of domains. And the nutrition assessment and reassessment and nutrition monitoring and evaluation steps use the same terms, but the terms for nutrition diagnosis and the terms for nutrition intervention are distinct. So the first step is nutrition assessment. So as I mentioned, the nutrition assessment is a kind of a comprehensive analysis of nutrition related problems in clients. And as a nutrition counselor or as a dietitian in general, we are collecting nutrition related information. And here, when we are collecting nutrition related information from clients, care should be taken to establish a report with our clients. We have to build a relationship with our clients. Even if we have like we are, let's say we are working in hospital or other clinical settings, and we have some limited times to build the relationship while we are doing nutrition assessment. But again, within that limited time, we have to build a relationship with clients, with patients. And we have 2 major functions in this step: the collection of timely and appropriate data. And we have to analyze and interpret the collected data in order to identify, in order to develop nutrition diagnosis as in our second step. So, when we are examining data obtained from assessment, we need to furnish baseline parameters. We need to determine health and nutrition risks. We need to certain feasible alternatives for making dietary changes and planning intervention. We need to identify strengths and roadblocks for making lifestyle changes. We have to set priorities for making dietary changes. We have to monitor progress and success of intervention strategies, and we need to anticipate appropriate outcomes. We have 9 domains in nutrition assessment: client history, food and nutrition related history, anthropometric measurements, biochemical data, physical exam. Physical exam is the nutrition focused physical exam, assessment, monitoring, and evaluation tools, ideology, and comparative standards, and progress evaluation. These are the main domains for nutrition assessment. So for the food and nutrition related history, we have different assessment tools that we can utilize. And the goal is to collect data to aid in understanding the kinds and amounts of foods and supplements consumed and the factors influencing choices. And since we have different dietary assessment tools, the selection of a particular tool depends on the objective of the interaction, initial or follow-up sessions, number of planned visits, employer requirements, and available resources. When we are collecting data, when we are doing nutrition assessment, we need to be careful not to give advice, preach, or condemn. This can be interpreted as judgmental and inhibit the free flow of information. Therefore, we need to remain neutral. We need to avoid words of approval. This will encourage a client to give information perceived as good answers. Some counselors suggest telling clients that there are no wrong answers. So if we are asking question about nutrition and dietary intake, we can tell clients that there are no wrong answers so they can, freely give accurate information. And we have to tell clients, these are suggestions. Telling clients not to be afraid to be upfront because no one has a perfect diet. We can also give an example of a low nutrient dense food that we enjoy. So if I enjoy French fries and if client eats lots of French fries, I can say, yeah, I also enjoy eating French fries, for example. So we need to be careful about this kind of behaviors. As I mentioned, there are different dietary assessment tools, and we will go over these one by one. And remember, each of these tools has advantages and pitfalls. By using more than one instrument, the probability of obtaining a clear picture of our client's nutritional status and problems increases. So we can combine different dietary assessment tools if we have time. And many dietary intake collection methods, they require clients to estimate or measure portion sizes. So we can have a sheet of these portion sizes and estimates, and we can ask clients these. Um, for example, for raw or cooked vegetables, we are using cup, or whole fruit or fruit juice. We use 1 cup. For a 1 ounce equivalent for grains such as pasta, rice, and oatmeal, we use half a cup, and so on and so forth. And I also provided a link here so you can also explore that further. So client assessment questionnaires, this is one of the dietary assessment tools. It also referred to as an intake or historical data form. It typically includes an administrative section questions related to medical history, a family health history portion, drug history questions, socioeconomic history, a dietary pattern section or dietary history, and a final section requesting clients to identify nutrition issues. So this is the format of client assessment questionnaire. We have also food diary and daily food record. So a client records intakes of foods and liquids, nutritional supplements, and herbal products, the preparation methods as well. And it generally is from 3 to 7 days. So this is food diary or daily food record. There's a limitation, which is the impact of recording on specific food intake. So if I'm going to record my uh, food intake, daily food intake for, let's say, for 7 days, um, I will try to eat healthy, right? I don't want to record all fast foods, processed foods, high sodium content food items. I will try my best to eat healthy, and I want to record those. So this is one limitation. We have usual diet intake form. So usual diet intake form, this one kind of, obtain clients' typical daily pattern of food intake. That's why it's called usual diet intake form. But remember, this is very important point. The usefulness of usual diet intake form will be limited for clients whose intake varies a lot um, from day to day. And in this tool, answering general questions would be difficult, and another assessment tool should be used. This form is simple and not time consuming to complete. So this is an advantage of usual diet intake form. And we have to refrain from asking leading questions, such as, what did you eat for lunch? We are assuming that the client has eaten lunch. So this is a leading question. We need to avoid that. And we can also use probing questions in order to explore more. So, for example, if client says, I ate bread for breakfast, we can explore more by asking, what type of bread was that, for example. Or the client says, I eat most of the time I eat bread for breakfast. We can say, what type of bread you are consuming most of the time. For 24-hour diet recall, we are asking clients to recall all foods, beverages, and nutritional supplements consumed, including the amounts and preparation methods over a 24-hour period. There are some different components for an effective 24-hour diet recall. We need to avoid leading questions. The questions assuming a meal was eaten. We need to refrain from prompts. For example, what did you eat for breakfast? So this is kind of a prompt, and this is kind of a like leading question. What did you eat for breakfast? We are assuming that a meal was eaten. It is better to ask what liquids or foods did you consume immediately after waking up today? We need to employ probing questions. What kind of bread was used to make the toast? Anything else put on the toast besides butter, for example? We can also ask sequential questions about the day's activities, travels, and encounters with others in order to help clients recall foods and liquids consumed. Inquire if any foods were consumed during meal preparation or cleanup or during the middle of the night. We need to use the portion size estimation tools and food models to improve the accuracy of the answers. We need to ask about food items that are missed in 24-hour diet recall, like crackers, breads, rolls, hot or cold cereals, cheese added chips, candy, nuts, seeds, coffee, tea, beer, wine, so on and so forth. And also we can use the multiple pass procedure, which is validated through USDA. And this is the 5 steps of multiple pass procedure by USDA. We have to have a compiling we need to compile a quick list. This will save time. We need to ask clients about items on the forgotten food list. We need to explore more on the time and occasion at which foods were consumed. We can also ask clients to provide more descriptions of foods. We need to ask clients about types, amounts, additions, and toppings. Diet history interview is another dietary assessment tool. A diet history interview mirrors asking clients about their usual day or a typical day or usual diets. Here in diet history interview, the emphasis is on minimizing questions and allowing clients to tell their stories. That's why it's called interview. Clients are invited to give an account of a normal day's eating pattern. This is kind of a similar to usual day food intake, but here we are asking more about like stories. So, and in this method, we can, as a counselor, we can use usual intake form and couple with a 24-hour diet recall. And you can look at Appendix C to find some, to find some like forms and templates. Food frequency questionnaire is another dietary assessment tool, and this is very common in research, I would say. In research articles, most of the time we use food frequency questionnaire. So this is an assessment tool containing lists of foods grouped according to similarity in nutrient quality and quantity. Uh, this can be either read to clients by counselor or distributed in printed form or online format. The food frequency questionnaire indicate how often certain foods are consumed by the day, week, month, and so forth. Some forms are specific for calcium or fat and cholesterol, but some are comprehensive. And food frequency questionnaires vary in the amount of detailed requests. So there are different forms, different types of food frequency questionnaire. Some of them are short, some of them are long. Some of them are specific, some of them are comprehensive, but and the methods of administration is also different. It can be in printed form or online or by phone, or it can be read to clients. So this is an example for food frequency questionnaire. Culturally specific techniques and tools for conducting nutritional assessments are critical. And in order to establish trust during the first session when we are trying to obtain data from clients, we may consider using a typical day technique or the diet history interview data collection methods in order to kind of build a report with clients. And depending on communication difficulties and cultural feelings about invasiveness, we can also find a qualitative rather than a quantitative approach to yield greater success. So food and nutrition related data was I would say the first domain. And we have also client history as first domain. So there are 9 domains for nutrition assessment: client history, food and nutrition related history, and this is anthropometric measurements, which is one of the 9 domains. So here uh, we have non-invasive quantitative measurements of the body, and we are uh, trying to assess nutritional status, growth, and weight. So body mass index is one of the anthropometric measurements. So, and and you know the formula for body mass index. It is body weight um, divided by body weight in kilograms divided by height in meters squared. And if we have body weight in pounds and height in inches, we need to divide body weight by height squared and then multiply that by 703. We can calculate BMI. And these are the categories for BMI and the risk. So here we have normal waist and um, high risk waist. So if we have BMI as underweight and we have normal waist, we have an increased risk for some health issues. And if we have normal BMI and normal waist, we have not elevated risk. But if we have normal BMI but high risk waist circumference, we have an increased risk for different health issues. So BMI can be categorized into different groups based on the value of BMI. Um, the classifications are underweight, normal, overweight, obesity class 1, obesity class 2, and obesity class 3. Remember, different race and ethnicity groups have specific cutoff points. So, the BMI we see here, the way we categorize it is different for Asians. And remember, BMI has some limitations, and it's not a standard tool to estimate body fat risk for pregnant and lactating people highly muscular people, growing children, or adults over age 65. Waist circumference is another anthropometric measurement, which is an indicator of upper abdominal fat. And the cutoff values for waist circumference in females greater than 35 inches, and in male it's greater than 40 inches. And here we have cutoff points for Asian males and females. And waist circumference, regarding waist circumference, there are two types of fat distribution. We have android fat distribution or apple shape, which is more common in men than in women, and it is closely associated with chronic disease like heart disease, stroke, diabetes, hypertension, and some types of cancers. We have gynoid fat distribution or pear shape, which is more common in women than in men, and this is not usually associated with chronic diseases. The gynoid fat distribution is more resistant to kilocalorie or energy deprivation and exercise. And this is how to measure waist circumference. Waist circumference measurements can provide useful data for an intervention where individuals with a normal BMI to determine disease risk, individuals with a BMI between normal and 35, and clients who have been making diet and exercise changes to monitor progress. Medical tests, biochemical data, medical tests, and procedures is another domain of nutrition assessment. So here we are kind of estimate total energy expenditure of our clients, especially when we are planning a weight management program. It is useful to estimate total energy expenditure. And remember from your other nutrition courses, nutrition energy expenditure has three components. We have resting energy expenditure, we have thermic effect of food, and energy expended in physical activity. And in order to calculate total energy expenditure, we need to multiply the energy expended in physical activity by resting energy expenditure. For the resting energy expenditure, we have different methods. We have indirect calorimetry, which is kind of very costly and time consuming. So most of the time, we don't have that tool to use in clinical setting or even in private setting. So we will use other methods. We can use formulas to estimate resting energy expenditure. Um, we Here is an important point for people with uh, who are overweight or people with obesity. It is very useful to use indirect calorimetry. But if it is not available, it recommends using the Mifflin equations for people who are overweight or obese. And here we have the physical activity level factors in order to calculate the energy required by physical activity, and we have different formulas. You don't need to remember these. You don't need to memorize these formulas. We need to analyze and interpret um, the data we collected in nutrition assessment. And in order to kind of analyze and interpret data, we can use some standards to compare the client's, estimations um, to these standards in order to identify a nutrition diagnosis. So we have food group evaluations, nutrient analysis, my plate, dietary reference intakes, DASH diet or dietary approaches to stop hypertension. We have mind diet, which is for clients concerned about mental decline. And this mind diet is based on Mediterranean and DASH diet, focusing on aging brain. Eat a variety of healthy foods each day. This is another, methods to compare the client's dietary intake to. And we have Chronometer, which is a consumer focused program. So this is an online or there are some app options to log food and exercise, plan meals, analyze recipes, evaluate nutrient intake, and track progress. The second step of nutrition care process is nutrition diagnosis. So here the goal is to identify and describe a specific problem that can be resolved or improved through treatment and nutrition intervention. Remember, in some cases, you may see different nutrition diagnosis. If there are more than one problem, we will have to have different nutrition diagnosis. And for nutrition diagnosis, we will utilize the data collected during the nutrition assessment in order to develop nutrition diagnosis. And as we mentioned in nutrition assessment, there are some, standardized terminology here we can use. And if there are more than one problem, we need to analyze which one or two are most likely to improve with the nutrition intervention. There are more than 100 nutrition diagnoses. And we can categorize nutrition diagnosis into four groups. We have intake nutrition diagnosis like inadequate, excessive, or inappropriate. We have clinical nutrition diagnosis related to physical or medical conditions such as swallowing, chewing, digestion, or absorption. We have behavioral environmental nutrition diagnosis, which is related to cognition, designations, and environmental factors. And we have nutrition situation diagnosis, include other information obtained from the client, such as the social determinants of health. So we have four um, categories for nutrition diagnosis. For the nutrition diagnosis, the terminology here is we have to have a definition of the nutrition problem. We need to mention possible etiology or the cause of the nutrition problem and common signs or symptoms. So for the nutrition diagnosis, we use PES statement or PES statement. PES stands for P stands for problem. So what is the problem? E stands for the root cause of the problem. Why does the problem exist? And S stands for signs and symptoms, or like the characteristics of the problem. These signs and symptoms needs to be measurable, objective, and subjective data. And these are the etiology categories used for PES statements. So when we are trying to develop a PES statements, we need to follow this terminology. We will have nutrition problem label related to etiology as evidenced by signs and symptoms. So nutrition problem label related to blank as evidenced by blank. So here is an example. So we have to say, for example, for the client who is 45-year-old male, we say inappropriate intake of fats related to frequent consumption of fast food meals as evidenced by serum cholesterol level of 250 and 10 meals per week of fried chicken and biscuits or hamburgers. For the second example, for the second client, we say breastfeeding difficulty related to poor sucking ability as evidenced by poor infant weight gain and fewer than 6 wet diapers in 24 hours. And for the third client, we say inadequate fiber intake related to inappropriate food preparation practices. For example, reliance on overprocessed foods as evidenced by estimated fiber intake of 15 gram per day. This is how we kind of format the PES statement in nutrition diagnosis. The third step is nutrition intervention, and the purpose is to resolve or improve the nutrition diagnosis or nutrition problems by planning and implementing appropriate interventions. We have two phases here: the planning phase of the nutrition intervention and the implementation phase. For the planning phase, we have prescription planning and goal planning. For the implementation phase, we have food and or nutrient delivery, nutrition education, nutrition counseling, coordination of nutrition care by nutrition professional, population-based nutrition action, and nutrition intervention in counter context. So these are the domains, 8 domains of nutrition intervention. The first domain of the third step of nutrition care process is prescription planning. So here we are providing a nutrition prescription, which is an essential component of nutrition intervention. So here, the nutrition prescription, needs to state the recommended dietary intake of energy and or nutrients based on reference standards, dietary guidelines, nutrition diagnosis, health condition of the client. And at follow-up visits, the prescription planning involves evaluating achievements or barriers to achievement. And for the goal planning, uh, we are trying to make successful behavior changes here. And goal planning or goal setting is an effective behavior change tool for clients ready to make a behavior change. That is, those at level 3 and possibly level 2 in the motivational nutrition counseling algorithm. Goal setting is a key strategy in motivational interviewing, cognitive behavioral theory, and social cognitive theory. Before discussing goals with a client, as a counselor, we have to talk them through technical terms related to their condition. So, health literacy is not about intellectual intelligence, but the ability of clients to understand their health problems. Clients have different numeracy levels, which are math literacy. So, individuals with a low level of numeracy may have trouble um, understanding the concepts related to blood glucose readings, carbohydrate counting, calculating dosages, or reading nutrition labels. So, health literacy is very important. And before setting goals or discussing goals with the clients, we need to address health literacy. So, if they do not know how to read nutrition facts label, we need to teach them how to do that. And we have SMART for goal setting. So SMART stands for specific, measurable, attainable, relevant, and time-based. So for the SMART criteria, we need to have a specific goal and we have to have measurable goals. We need to determine attainable goals and we need to set relevant behavioral goals and time-based goals. And here are some examples for SMART goals. So for example, eat 2 servings of vegetables for lunch and again at dinner for the next month. So this is specific, this is measurable, achievable, relevant, relevant to blood pressure, and it is time-based. We have like time mentioning here in this example. So here are some examples for SMART goals. There is a tool called option tools. By utilizing option tools, clients feel a sense of ownership over the plan for goal setting. So instead of dictating goal to clients, we can use option tools. So they can choose their own goals by using the tool, which we see on the right side of the slide. Um, when I say dictating goals, it doesn't necessarily mean that when we are developing goal, we have to use option tools. It's not that. I mean, we can utilize option tools, and this is like this methods has its own advantages because it makes clients feel the sense of ownership over the plan for goal setting. So after setting goal, we need to design a plan of action. Um, so Once a well-defined, achievable, and measurable goal has been identified, but the next step is to design a plan to implement the goal, right? And we need to kind of, we have to be aware of different factors for a well-developed action plan. We need to investigate the physical environment. We need to examine social support, uh, client's cognitive environment. Um, we can also modify goal if necessary. We have to select a tracking technique and verbalize the goal and write down the goal. Coordination of nutrition care addresses the implementation phase of the third step of nutrition care process. So nutrition intervention and is one of the domains of this step. So this domain of nutrition intervention. So coordination of nutrition care is one of the domains of nutrition intervention. And this domain stresses communication of the nutrition care plan to all relevant individuals. So this can include referring clients to other health providers, such as psychologists, physical therapists, speech pathologists, or occupational therapists. Um, so coordination of nutrition care, it's very important in clinical setting, I would say. This is more important in clinical setting than in private setting. Um, but when we are kind of trying to do nutrition intervention, we have to have a clear communication with other healthcare providers in hospital or other clinical settings. Let's answer this question. Some, small past successes are important when helping a client define a specific goal. So, in nutrition counseling and as a nutrition counselor, we might ask clients to come up with their own goals. And we can ask clients to kind of determine or to identify a specific goal by using their own past successes. But why? Why is this important? What do you think? So by kind of using small past successes, we are providing a foundation for setting achievable goals. So if our client has not clearly stated a specific goal, we can explore past experiences with our clients. Successes of the past, no matter how small, are useful starting points for defining an achievable goal. The last step is nutrition monitoring and evaluation. Remember, the terms used in this step is similar to the terms used in nutrition assessment. Um, Here are the definitions of nutrition monitoring and nutrition evaluation. So, nutrition monitoring is the periodic reviews and measurements of the client's nutritional status. But nutrition evaluation is a systematic comparison of current data collection and measurements against criteria and some standards. Documentation and charting is very important. in nutrition care process, because by charting and by documentation, we are providing evidence of care. We are kind of providing a basis for evaluation and planning. Um, we are documenting for legal protection of clients, practitioners, facility, and so on and so forth. And also, for nutrition care process has its own documentation and charting, and this standardized methods or language uh, help us as dietitians and counselors communicate with other healthcare professionals, so we can use a dime like the letters um, for the all steps of nutrition care process. And this formatting facilitates the nutrition care process model. Um, Practitioners using the nutrition care process model are not required to use the ADIME charting format because many health facilities have established charting requirements. So, um, if we want to like work in hospital or in like different clinical settings, they may provide their own like charting and documentation format. So we don't have to use a dime format. And there are like some guidelines for documentation for different steps of nutrition care process. So here we have charting for nutrition assessment, charting for nutrition diagnosis, charting for nutrition intervention, and charting for monitoring and evaluation.